Yeah. All right. So my name is Dave Thut. I'm an orthopedic surgeon at Seacoast Orthopedics in Somersworth. We practice here and at Frisbee. We have 9 surgeons and a primary care doctor, and I think we're up to 7 or maybe 8 physician's assistants. So a relatively big practice and relatively subspecialized practice with pretty much the full breadth of orthopedics. My specialty is sports medicine. So my education is I grew up in Baltimore and then went to college at Dartmouth College, which is part of how I ended up circling back here. And then went to Penn for medical school. I did my residency, so for orthopedics it's a 5-year residency training after medical school in Rochester, New York. And then I went and spent 7 years as an orthopedic surgeon in the Navy and took care of a lot of athletes and really young people with athletic kinds of problems, and enjoyed doing that. And then ended up doing a sports medicine fellowship. And what sports medicine fellowship really means at this point is not only taking care of athletes, but taking care of the knee and shoulder basically through the whole sort of life cycle. So a lot of specialty training on arthroscopic surgery, and so I do mostly knee and shoulder surgery. So my thought for tonight, I have a whole talk that's sort of put together with PowerPoint slides, and I'll try to use that as a little bit of an outline. And then over the last several months, I've been using an iPad app that is put out by a company called Orca Health. That is I find, fantastic tool for sort of showing what we're really talking about with sort of 3-dimensional models and animations. And so I'll sort of use this as a little bit of an outline, and then we'll go to that. And I'd like it to be as informal as you know we can have it be. How many people have shoulder issues? Is that why you're here? Yeah. And what have you been told that they are for the most part? Do you have any idea? Rotator cuff problems, or?
All rotator cuff tear.
Yeah. Don't know. Yeah.
Capsulitis.
Adhesive capsulitis.
Posterior.
Yep. So those are sort of the most common problems in the age group of people that we have here. So I have the talk sort of set up so that it goes most common problems in this age group to sort of less common problems, and then to sort of younger people stuff. So we'll see how far we get. So the shoulder is a pretty complex joint, actually. You think of it as, or a lot of people think of it as, a ball and socket joint, and that's true. There's a ball and socket in the same way that the hip joint's a ball and socket. The hip joint, however, just is a ball and a socket. That's all that's there. And so you don't have a whole lot of motion in your hip. You have about 100 or 120 degrees of motion in your hip. Whereas in your shoulder, you have to be able to get all the way up overhead. You have to be able to get behind you. You have so much range of motion that you need to be able to do. So in order for that to happen, you have a ball and socket joint that allows a lot of motion. And then you have your shoulder blade that sits on your back. And it really doesn't have any attachment to your back at all. The only attachment that it has is through your collarbone, through your clavicle. And so your shoulder blade actually moves on your back, supported by a bunch of muscles on your back. So in order for you to lift your arm up, you have to have motion through a whole bunch of different joints, even though it all together sort of makes a shoulder joint. So the first joint is the acromioclavicular joint, which is the joint between the collarbone and the shoulder blade at the acromion. So it's this joint. The second joint is the scapulothoracic joint, which is just with your shoulder blade sitting on the back of your thorax, on the back of your chest. And that's attached just with muscles. And then the ball and socket joint is the glenohumeral joint. And as you lift your arm up, about 2/3 of that motion comes from the ball and socket joint, and about 1/3 of it comes from the shoulder blade moving on your back. So in order to get a lot of motion, the ball is very big relative to the socket. So unlike your hip, which has a lot of stability but not very much motion, it has a very deep cup and a relatively small ball relative to the cup. The shoulder is more like a golf ball sitting on a golf tee. It's got very small cup, very big ball, which allows you to have a lot of range of motion, but you sacrifice stability, meaning that it doesn't just get encapsulated by the bone of the socket. So one of the tricks that your body uses to try to help that is that there is around the cup of the shoulder joint, if this were the cup of the shoulder joint, around the cup is the labrum, which is a soft tissue that helps deepen the socket of the shoulder joint, and adds a little bit of extra stability and a little bit of depth as well. Here's somebody wanting to come in. So in order to hold that all together, there's a bunch of ligaments, which is soft tissue. So bone is bone, obviously. Ligaments are soft tissue that hold bone together. Tendons are soft tissue that hold muscle to bone. Okay, so the ligaments that hold everything together go from the cup of the shoulder joint across to the ball of the shoulder joint. And then there's also ligaments that connect the collarbone down to the shoulder joint. It's the shoulder blade. So those ligaments have to have a certain amount of flexibility in order for your shoulder to be able to move. So the best way I've ever figured out to show this is that if you look at the way my shirt is when my arm's just coming across, there's wrinkles across the front of my shirt, right? As I move my arm out like that, that shirt tightens up. The same thing happens with those ligaments. Those ligaments in the front of the shoulder when you're like this are relatively lax. As you go out, they tighten up. The opposite happens in the back. They're tight in the back when you're like this, and then they loosen in the back as you come out like that. So if those ligaments get so that they're the wrong size, if they're too big, the shoulder's relatively loose. If they're too small, the shoulder's relatively stiff. They need to kind of be just right in order for everything to work right. So if you take the ball away and you just look straight into the socket, there's that labrum that goes all the way around, and then all those ligament attachments all attach into that labrum that goes all the way around. Then the biceps tendon, the way your biceps works from your biceps muscle is it's got two parts, which is why it's biceps. And the first part attaches up here on the coracoid, which is a little process that comes off the shoulder blade. The second part is this thin little tendon that comes up and it goes under a little ligament and then it goes under your rotator cuff muscles and ends up inside your shoulder. So that can be a pretty significant source of pain as it goes through your shoulder as well. And then the final thing is the rotator cuff. And the rotator cuff is a group of muscles. So there's 4 muscles of your rotator cuff, and the tendons all sort of come together, as I'll show you here in a second. And they come together as a cuff on the humerus, on your upper arm bone. Their job is to help make up for the fact that the capsule isn't as tight as it could be, and they're just pulling the ball into the cup all the time. So as they contract, they're pulling this ball down into the cup to keep it stable. And they're involved in the motions of your arm as well. So let's see if we can make this work. So don't tell anybody my password. So this is a model looking from the front of the shoulder, okay? So let's see if we can blow it up a little bit. So this is obviously the collarbone. This is the shoulder blade here. This is the humerus, okay? And if we go all the way down to just the level of the bone, you can see again that the collarbone would have some ligaments that would hold it here. This is the shoulder blade. This is the humerus. Here's the ball of the shoulder joint and the cup of the shoulder joint, okay?
So
and
are we looking at this line from the rear?
you're looking at this from the front as if the chest isn't there. Okay, so this is sitting on the back,
Yeah.
but it's as if the chest isn't there. And if we spin it around, that's what it would be looking at it from the back.
Okay.
Okay, so that's the scapula, the shoulder blade, yep. And then the next layer out on that are those ligaments. And the ligaments, again, there's the ligaments that hold the collarbone down. And then these are those ligaments that are kind of like what my shirt is, that hold the ball and socket together. And you can imagine as you lift your arm up, let's see, as you lift your arm up, those ligaments have to be able to give in order to allow your arm to lift up. And then once you get to the point where those ligaments have gone as far as they can go, your shoulder blade has to start to move in order for your arm to go all the way up overhead. So if those ligaments get too tight, then that makes it hard for things to move, okay? Then the next layer out is your rotator cuff muscles. And those rotator cuff muscles, again, come off the shoulder blade here, and they attach up here on your upper arm bone, on your humerus. Come on. There's a couple things to point out about that. One is that if you look at them from the side, they all 4 sort of come together. So this is one, this is one, this is one, this is one, and they all basically merge together as they attach. The second thing to notice is that the biceps comes up and it goes underneath this front part of this rotator cuff. The third thing to notice is that this bone right here is called the acromion. That's the top part of your shoulder blade. And the top muscle of your rotator cuff has to come right underneath that bone. Where it comes out is right underneath that bone. And there's a thing called the bursa, which is a little layer of tissue that's a lubricating layer that's between the rotator cuff and the acromion. And then the final thing to point out about the rotator cuff is if you look at the angle, so if you look at the angle that this muscle pulls, in general, it's pulling the ball down away from that acromion bone. If it pulls, that makes sense? Everybody see that? So if you lift up on your arm here with looking at that top muscle of the rotator cuff, as you lift up on your arm, you can imagine that that top muscle of the rotator cuff would rub up underneath that bone and get that bursa irritated, or could do that. And then the final layer of tissue is your deltoid, and that's the superficial muscle. So your deltoid muscle is the main muscle that raises your arm up, and then the rotator cuff helps sort of keep everything in place as it's doing that. That helpful? All right, so all of those different areas of the shoulder can be reasons for shoulder pain. So you can have arthritis. And what arthritis means is that I forgot to point out the smooth surface of the joint, but every joint has a smooth surface that's like a veneer on the surface of the bone. And as that smooth surface wears out, that's what arthritis is. So you can have arthritis in the ball and socket joint. You can have arthritis in what's called the AC joint, where your collarbone meets up. You don't really get arthritis in the joint between your shoulder blade and your body because there isn't any cartilage there. There's just muscle sort of attached to muscle. You can have ligament problems, which would be tears of that labrum or where all those ligaments attach in. Or you can have adhesive capsulitis, which is frozen shoulder, which is what you were talking about, and we'll get to that. So the ligaments can be too loose, they can be torn, or they can be too tight. And then the final thing is you can have problems with the muscles and tendons, like the biceps tendon or with the rotator cuff muscles. So how many people have heard, well, let's see where we are. So how many people have heard of bursitis, have friends that have said they had bursitis? Yeah? How about tendinitis? How about rotator cuff tears? How about calcific tendinitis? No, that one you haven't heard. So all those things are all the same spectrum of disease. So it's all those things. Some people will come in and they'll say, well, you know, one person told me I had bursitis and one person told me I had tendinitis. And those are basically synonymous. They basically mean the same thing. They're all part of the same problem. It just progresses sort of through stages to get worse and worse as time goes on. So the reason the rotator cuff has problems is that it, as we talked about, it kind of rubs under here. And when you're young, there's great blood supply to your rotator cuff. So it can rub, it can get twisted, it can get bent, and it heals reasonably well. So the people who are young that get rotator cuff problems are pitchers because they're putting a tremendous amount of strain on their rotator cuff and that can't keep up. But very few 20-year-olds get shoulder pain from their rotator cuff just because. Whereas as we get older, that rotator cuff tendon isn't quite as supple, and there's an area where the blood supply isn't quite as good in here. So that means that as you get older, less and less trauma to that tendon is harder for your body to heal because it just doesn't heal as well there. And it particularly doesn't heal as well there because of that blood supply issue. So that's what we were just talking about, that those are all more or less the same spectrum of disease. So people with rotator cuff problems come in, they typically complain of, my shoulder hurts here. So even though your rotator cuff's sort of deep in, the shoulder tends to sort of hurt out here, or sort of in the front of the shoulder. It's not usually in the back, it's not usually along the shoulder blade, it's kind of out here. It tends to be worse at night, not clear exactly why. It tends to hurt reaching up overhead, so people talk about getting stuff out of the cupboard hurts. Reaching behind your back, so women talk about doing their bra strap hurts, or tucking a shirt in, or putting belts through a belt loop hurts. And then as you get more and more of damage to that rotator cuff, you may start to notice that you have weakness. It's hard to reach up overhead. And if you have a big enough tear, particularly an acute one, it may make it so that you can't lift your arm up overhead. All right, so the first thing is rotator cuff impingement, and that's what we were talking about where the tendon rubs up underneath the bone. And that can cause inflammation of that layer under there, which can cause bursitis. And it can also cause inflammation and irritation of the tendon, which is tendinitis. But all those things are more or less the same thing. So if we go back to this thing, if we can make it work again. If this works all night, I'll be amazed. So This is a little video, a quick video of sort of what impingement's all about. So this bone up here, the more curved it is, the more likely it is to rub on that bone. So some people are designed with a really significant curve, and some people have a relatively flat curve. And it doesn't doom you, if you have a curved one, it doesn't doom you to having problems. But on average, if you have the more curved your acromion is, the more likely you are to have trouble with your rotator cuff. So again, that's that bursa over top, the smooth layer, which is happy when it's not rubbing and then gets unhappy as it's getting rubbed. So there you can see in this person, this is an x-ray here, where this person has a really significant hook on the front of their acromion so that it tends to push against the rotator cuff. So that's what we call impingement. The video for bursitis is really the exact same thing. It just shows that that bursa gets inflamed over top. So that's sort of the beginning stages of things. So the treatment, well, let's go.
You get the bursa to settle down.
You can. So the treatment for this is anti-inflammatory medications when you're at this level. So Motrin, Naproxen, those sorts of things. We can do a cortisone injection, which is a pretty high-powered anti-inflammatory, the cortisone. And we can do that injection. We just do it right there into that bursa. It's pretty easy space to get to because it's right underneath that bone. And that can help settle down the inflammation. But the thing that really fixes it isn't the anti-inflammatories and isn't the cortisone. What really fixes it is doing exercises to get everything working right again. So you can imagine as your arm goes to lift up and that rotator cuff needs to, that shoulder blade needs to get out of the way. If the muscles that support your shoulder blade aren't working exactly in symphony with the rest of your arm, your shoulder blade doesn't get out of the way in time and your rotator cuff hits that bone. If your rotator cuff is, we talked about how the front muscle pulls down a little bit. If your rotator cuff's a little bit weak or isn't working quite as well, it doesn't pull the ball down to give itself space underneath that bone. So there's a lot of things about the mechanics of the way the muscles are going that can cause it to rub more and can give it more trouble. And if those things don't work, those things work the vast majority of the time in somebody that has just that level of rotator cuff disease. If they don't work, though, the next step surgically is a thing called an acromioplasty. And so what we can do is we can go in with the scope and we can take that acromion that's hooked like this. The very first thing that we do is we actually go in and we take all that inflamed bursa out. So we have a little shaver that has suction attached to it to take all that out. And then there's a little burr that it looks almost like a little Dremel tool that you can use to smooth off that front part of the bone and give it a little bit more, give the rotator cuff a little bit more space. So, huh? What's that? Do you get your bursa back? It grows itself back. It grows itself back. So the bursa, the way people talk about bursas, sometimes you hear people say it's a fluid-filled sac. It's really, a normal bursa is more like a Ziploc bag that has a couple drops of water in it. So you can imagine that the surfaces of the bag are now able to slide by one another, but it's not really full. So like underneath the skin at your elbow, there's a bursa, and that's what allows all this tissue to move relative to the underlying bone. So once you take that bursa out, there's still going to be layers that are moving relative to one another, and your body just magically figures out how to put a new surface on there and make a new bursa. And when you go back in, if you need to go back surgically to somebody, there's still good bursa space there. So do you want to see a real video of what that looks like, or was the pretend video good enough?
Yeah.
All right. All right. So I'm not sure exactly, I don't remember exactly how long this is. So this is looking inside a shoulder. The rotator cuff is, this thing moves around a whole lot, but the rotator cuff's down underneath, and then that acromion bone is up on top. And we pump some fluid into the shoulder to be able to distend it and see a little bit, so you'll see bubbles in the fluid. That's the little Dremel tool, the little burr. And so the curved front is up here, and then that burr just can grind that tissue away in order to take away that little spur that's on the front, the little curvature that's on the front.
Where's all that detritus go?
It gets sucked out. The shaver actually has suction attached to it, so it just sucks right out.
Unbelievable. Did you used to do this before arthroscopy?
Yep. So this was actually described, I don't know how long ago, years ago, by Dr. Neer, who was a guy in New York City, and he did it. We used to do it by making a big incision in the shoulder like this, sort of going through the deltoid, and then you'd taken a saw to take that off. And it wasn't that long ago when I finished my residency in 2000, and it was sort of, I started by the end of my residency, we started doing them this way. At the beginning of my residency, we were doing them all open. And then rotator cuff repairs, even at the end of my residency, we were doing open with a big incision. And now the vast majority of those are done through the scope. It was a relatively quick transition. Any questions on those things?
It's the recovery, like.
After this, so this is actually relatively uncommon operation to just do this. It used to be more common. After this, there's really, if this is what you have, there's really no restrictions afterwards. You're in a sling for a couple days to just let things quiet down, and then you can start slowly moving your shoulder again. You do some therapy. And typically, within 6 weeks, things are feeling quite a bit better, and you're kind of functional within a couple or a few weeks. Yeah.
After that surgery, can that re-inflame?
The bursa can re-inflame, yeah. That's why, so it's important after you, with any of this, and I think probably with acromioplasty, part of what helps is smoothing off that space, but more of what helps is the physical therapy afterwards, I think. Once you get the bursa to quiet down, and then you can really focus on getting the muscles to all work, that's probably at least as important as anything that the surgery did. So in some people, once that tendon sort of gets inflamed, your body responds to that by laying down calcium inside that tendon. And then that calcium ends up being an irritant. So the calcium gets put there because things are irritated, and then the calcium itself makes things more irritated. And so this can come on sometimes very abruptly and very painfully. Sometimes it can sort of develop over time, but sometimes this can be a really quite acute onset thing where all of a sudden your body starts laying down this calcium and really making things hurt. Where is that? So again, here's your normal rotator cuff there, and what happens is that it starts to swell as that calcium builds inside it, and then there's really just a ball of calcium there. And that at the beginning, it's almost the same consistency as toothpaste. So you can, if you get to it relatively early, if you can't get it to quiet down conservatively with injections and those sort of things, sometimes you can just make a little slit and you can get all that toothpastey stuff out of there, and then your body sort of re-heals it. Sometimes it ends up that there's so much calcium that by the time you take it out, there's sort of a hole there and you end up needing to do a repair. Yeah.
Can you see that with X-ray first?
So I don't know why it's sort of there. There we go. So that's an X-ray looking from the front. So this is the ball. Here's the cup. The rotator cuff lives up in here, and there's that calcium right there in the tendon. No, you can't. You can't see the inflamed bursa. It's just because it's just soft tissue that you can't see. So this one is a larger calcium deposit. You can see this one's a little bit sort of cloudy looking, which means it's still soft. And that's big enough that probably needs to surgically come out of there because it just leaves a big gap in the rotator cuff if you don't. Sometimes you see just a little itty bitty one like that, and that most of the time doesn't mean a whole lot. So that just means somebody's had some irritation of their rotator cuff, and we see that, and yes, that's calcific tendonitis, but that's sort of not the classic acute calcific tendonitis. And sometimes we go in and need to take that little piece out, but at the same time, we're smoothing off that acromion bone, all those sorts of things. Questions on that? So the treatment for calcific tendonitis is just like the bursitis, is to exercise and strengthen up the tendons, cortisone injection, anti-inflammatory medicines. And then the other thing we didn't talk about is you can do what's called dry needling. So you can see that calcium with an ultrasound machine. And so you can look at it with an ultrasound, and my partner, Dr. Brennan, does this, and then he can just use a needle and poke a couple holes in that tendon, and then that soft, sort of gooey calcium can work its way out of the tendon. Sometimes it works its way right out, and that takes care of it, and it's able to heal behind that because putting the needle in there also encourages new blood supply in there, so it encourages healing. So sometimes you can get by with just doing that. Sometimes you end up having to take it out surgically. And then if things get really bad, you progress all the way on until you have a rotator cuff tear. So, and when a tear happens, the video will show this pretty well, the muscle actually pulls away from the bone. It's pretty uncommon for it to tear right in the middle of the muscle. It usually is the tendon itself where it attaches to the bone comes off. And it can involve, usually it involves this top tendon, which is the one that kind of Dr. Neer described rubbing underneath this bone. But it can, because the tendons are all connected, that tear can extend all the way back and can involve usually these top two tendons, and it can come all the way down and involve the front tendon as well. So that tear can get pretty big and can cause quite a bit of dysfunction. So they can be caused by a single traumatic event. That's usually somebody that's had some rotator cuff underlying tendinitis, rotator cuff disease, and then they fall on it or they do something to it that causes that muscle to pull really hard and it pulls off. But more commonly, it's just sort of years of kind of your shoulder getting worn and it kind of chafes through. The incidence there, I don't remember the exact numbers, but there were studies that are probably now 50 or 60-year-old studies where they looked at cadaver bodies and they looked at what's the incidence of rotator cuff tears in these people. And it turns out the older you get, the more likely you are to have a rotator cuff tear. And these are people that had asymptomatic shoulders. So you can have a tear of your rotator cuff without it being a problem, but if it hurts and it's a problem, then you ought to fix it. So they aren't always symptomatic.
Can the tear ever heal itself?
It won't heal itself, but it can stop hurting because the way the muscles are attached, it can sort of still pull around the tear. So if you can get it to stabilize and you can get it strong, it can be asymptomatic, but it doesn't heal itself. So when I was a resident, our thought process on rotator cuff tears was that, when I took boards 15 years ago, somebody was supposed to do physical therapy for 6 full months before you considered fixing their rotator cuff. And then the idea was that if there's all these people out there that have rotator cuff tears that aren't symptomatic, if we could take somebody that has a rotator cuff tear and turn them into one of those people that's asymptomatic, then great, they aren't having symptoms from it. As the level of invasiveness of repairing rotator cuff tears has gotten less, so that we don't have to take your deltoid muscle down, we don't have to make a great big incision. The risk-benefit analysis of, geez, should we fix this or should we not fix this, has tilted more toward, yeah, maybe we should fix it because the risk isn't as high to fixing it. And then there started to be some studies to say, well, what happens to those tears if you don't fix them? And it turns out that 40% will get bigger, and one study showed 80% of them will get bigger and eventually become symptomatic. So they don't tend to just stay there. They tend to get bigger over time. Now, that doesn't mean that if you have a tear that isn't hurting, you should fix it. You should just pay attention to that. But if you have a tear that's hurting and it's big enough, then you probably should fix it because it will have a tendency to get bigger. So again, we now rarely do these through an incision. And typically, for me, I do a few a year through a big incision, and those tend to be tears that are really big and involve the tendon up in the front of the shoulder, but most of them are through the scope or with the scope.
Is there any similarity of that to the meniscus tears in the knee?
No, yeah, I mean, it's to some extent because there's a piece of stuff, but this is really more of a mechanical detachment where the muscle isn't working anymore, whereas that's a piece of bumper tissue that isn't doing its job, but isn't getting pulled on. So let's see, rotator cuff. So what a rotator cuff repair? So what first? I skipped a step here. Sorry. So rotator cuff tear, wherever that is this. So that rotator cuff, as we talked about, attaches into the bone, and what happens is that it pulls right away from that bone. So you can imagine, you could have, the muscle is all coming here, and it comes down, and it needs to apply force to the bone here, right? If this tear is small enough, there's still, this muscle fiber can pull on its neighbor and pull on its neighbor and pull on its neighbor, and it still gets its force all the way down here to the bone. So if that tear sort of stabilizes and isn't too big, all those muscles can still do what they need to do, even though there's a small part of it that isn't attached. And then the bigger that tear gets, you can imagine that it could, over time, it could pull a little bit more off and a little bit more off, and it can eventually, because those tendons are connected, work its way all the way around. And that's something that, so the diagnosis of that, you can do this diagnosis based on ultrasound, or you can do the diagnosis by MRI. So I wish this thing showed a normal MRI, which it does not. But so this is the MRI is as if you get put in a meat slicer. It takes sections of you, okay? So this is looking from the front. This is the ball. This is the cup of the shoulder joint. And then this is that acromion bone that things rub on. And there should be rotator cuff tissue between the ball and that acromion. And the rotator cuff tissue is all the way over here. So this tissue should be pulled all the way over here. And what happens is that the muscle fibers over there contract and pull that rotator cuff away. And so it's no longer affixed to the bone. I don't think that there is, yeah, there's not one that shows a normal MRI. I wish there were.
You do a reattachment?
Yep, so the way you reattach it is to put some sort of a little, you go in and we clean up the edge, again with that same little shaver that we can take the bursa out with. And we would smooth off the acromion bone like that picture that I showed before. So we would do that part of the operation too. And then you have to have some way to reattach this tendon back to the bone with stitches. And the old traditional technique was to weave stitches through the tendon, and then we drilled holes in the bone and we passed those stitches down through the bone and tied the stitches down here over a bridge of bone. And then these are called suture anchors, which used to be metal screws like that went into the bone, and it's like a drywall anchor or something that has a little stitch attached to it. Those have then become, now you can still do metal ones, but you can also use ones that are made out of a plastic called PEEK. And you can use ones that are made out of calcium that actually theoretically absorb, and your bone sort of grows into them, and they allow the bone to sort of regrow so that they essentially disappear. And then the anchors that I'm using right now are made all out of stitch material. There's nothing at all there other than just stitch material. And so you drill a hole in the bone and push it into the bone, and it's got this knot that sort of deploys inside the bone so that it stays. So anyway, so you put some anchors in there, and then there are a bunch of different ways to do it, but you'd pass the stitches up through the tendon. And eventually you pass all those stitches up through the tendon, and then using a special little thing for tying knots, you tie those stitches all down, and that brings the tendon back up against the bone. The issue with that, though, is that if we can get, surgically, we can get this back up against the bone, but we can't make it heal. Right? So the issue is that the biology that caused this thing to tear in the first place is still there. So the predictability with which the bone, in order for this to last forever, the bone and the tendon need to get fixed together. The stitches will eventually pull through the soft tissue. The things that predict the likelihood of that are how big a tear it is. Obviously, the bigger the tear, the less likely it is that it will heal. How long the tear's been there. If you've had a big tear for a long time, it's just that tissue is not as happy as the tissue would be if the tear were newer. And then whether you smoke, smoking decreases the chances of this healing dramatically. And then the final one is just your overall health. So, obviously sort of the better you're healing and the more healthy you are, the more likely will be to heal. And in a relatively small tear that's relatively recent in a young person, the chances are probably above 90% that will actually heal. In a really big tear, that's been there for a while, the chances might be 50% that it will actually heal. What's interesting is that there's pretty good evidence that even if it doesn't heal, people tend to feel a little bit better. But I think there's a better video of that.
What's the PT in that?
So after the surgery, you come out of surgery and you're in a sling. And the sling really keeps your arm right to your side. So that what's important is that top muscle, that supraspinatus muscle, part of its job is to help you lift your arm up. So if you actively use your muscles to lift your arm up, that muscle is going to pull, and it's going to pull against those stitches and tend to pull them out. So for the first 6 weeks, depending on how big the tear is, 5 weeks, 7 weeks, somewhere in that 6 weeks range, you don't use your muscles actively to do this at all. You can move your elbow, you can lean forward and kind of let your shoulder roll around. You can let gravity move your shoulder, but you can't let your own muscles move your shoulder. And typically what I do is see people back about 10 days after surgery. and we make sure everything's looking good. And at that point, I give you a physical therapy prescription, and then it takes another week or so to get into therapy. And so people usually start therapy about 2.5, 3 weeks after surgery. And the therapy at the very beginning, they're lifting your arm. They're teaching you to use pulleys to do those sorts of things, to lift your arms up and get things stretched out. And then around at the 6-week mark, you start lifting your arm up on your own, but not lifting anything more than, I usually say nothing more than a coffee cup. And then somewhere around 3 months after the surgery, you start slowly strengthening that rotator cuff. And over time, hopefully it heals completely back down. So you want to see a real video of that? So this is a video that I took off the internet it's available on YouTube. So that's the rotator cuff tissue right there, and you can see this is the tissue. It should be attached to the bone down here. You shouldn't have that hole. So that looks just like that animation that we had. So here comes the anchor. That's one of the plastic anchors. So it screws down into the bone.
How big is that anchor?
There, it looks huge, right? It's about 4.5 millimeters across. So they're really pretty small, and most of them are about 15 or 18 millimeters long. So they're really pretty small. So then the inserter comes out, and then there's there's 2 stitches that are sort of looped through there, attached. And you see, he just gave it a little yank to make sure that it was tucked. And then there's a bunch of different instruments for doing this. I actually use one that's like a little set of jaws that passes the stitches through. But it sort of depends on what direction you want to look with the camera. In this case, there's a little hook that comes out through that needle, and the little hook can grab that stitch and pull it right up through the place where it just came through the rotator cuff.
So are you looking at this when you're doing the job, or are you looking at?
The patient's here, and you're looking at a TV screen as you do this. That's what you see. Yep, that's what you see.
The simulators that you train on, I assume.
There actually are starting to be some pretty good simulators. There are starting to be some pretty good computer simulators. When I trained, there are a bunch of models that you can sort of do this sort of in a model to get used to where your hands are going. But really, for most surgical things, there's parts of this that are, at the beginning, there are some instruments that you pass that stitch, and then somebody else needs to come in and now grab the stitch. So the more skilled surgeon passes the stitch, but then the less skilled person, the assistant, comes in and grabs the stitch. And as you get more and more comfortable grabbing the stitch, then you sort of can progress to passing the stitch. So it's the way that surgery sort of gets taught is that you start by doing the stuff that gets your hands and everything working, but isn't quite as important, and over time you build into it. So anyway, so at the end now he's got that tied down, and yeah, so there's a bunch of different knots that people have described that need to be able to sort of slide down in order to hold the tissue down. But so that ends up, and I actually do another, so he did a lateral row. So he actually did another anchor that he didn't show, but that holds everything nicely down on the bone. And then you hope that tissue and the bone are going to heal together. Questions?
How many people, what's the percentage of people where this tie, maybe it comes untied, or it doesn't work?
That it does, well, that's what I said. So a relatively small tear, it heals 90-ish% of the time. But with a really big tear, it can be less than that, like 50% with a really big tear. And sometimes you get in there and the tear is so big and it's been there so long that there's just no tissue to repair. So sometimes you get in there and it's just, I've actually had 2 of those in the last 2 months where it just, you get there and the tissue just won't come back to where it needs to come to because it's been in its new position for so long, or it's so sort of worn away. Fortunately, that's relatively uncommon.
How about anesthesia during these different procedures?
So typically for me, you're asleep. So the position for this, some surgeons do this with the patient sort of sitting up in what's called a beach chair position, sort of reclined a little bit. And others of us do it with the patient on their side and the arm sort of held up in traction. That's not a very comfortable position to be awake. So most people are asleep for the surgery. And then what you do for an adjunct kind of pain management differs by surgeon and by institution. And what we tend to do is have the anesthesiologist do what's called a block, where they numb up the nerves that go to your shoulder. And that lasts 12 to 18 hours or so. And then you get put to sleep for the surgery. And then by the time you wake up after the surgery, you don't have a whole lot of pain because that block's there. And then over the next 12 hours or so, that sort of slowly wears off and you can start taking some pain medicine. And then usually it's about a day to a day and a half that's not much fun. And then it seems to, I mean, I obviously haven't had this done to me, but it seems to just kind of magically get better after 36 hours. It seems as if things sort of settle down. And then it's obviously achy for a while, but it tends to get better relatively quickly.
So is that less time and less pain to do the tear than it is for the previous procedure, the impingement type with
Less time and
the calcium and...
yeah, with the repair. So when you take that calcium out, and oftentimes you end up with a hole that you have to repair. So, but this is a much bigger deal than doing just the smooth off the bone spur acromioplasty. Longer rehab, longer time in a sling.
For this?
For this.
Yeah, okay. That's
Longer operation. So then, let's sort of just, let me just see. All right, so there's a couple more things to talk about here, and then I want to show a couple quick exercises of things. So, so biceps tendinitis, we talked about that biceps where it comes through the groove in the, where it comes through the groove going up into the shoulder, that biceps can get inflamed and bothersome. And so sometimes that can cause pain just in and of itself. Sometimes it's part of what's causing pain when your rotator cuff is giving you trouble. So this shows actually what happens as the thing tears, but right in that groove where that biceps comes, that can chafe and rub, and eventually can chafe and rub through so that it completely tears. The good news is usually that once it tears, it stops hurting. So people come in, we see people pretty often that come in and they felt a pop lifting and something gave way up here, and you don't do anything about that. That usually fixes the problem. They have maybe a little bit of a cosmetic difference of their biceps from one side to the other, but usually they get better, unless they have some underlying rotator cuff disease as well. And so...
You've lost the attachment though, right?
Yeah, but it doesn't cause any weakness. It causes minimal weakness because the other part of it's still attached. So this part detached, but this whole part of the bicep's still attached. And this doesn't really shrink down all that far. It still has reasonably good strength. So in terms of the things you think of your biceps as doing, which is doing this, there's another muscle called your brachialis that actually does more of this than your biceps actually does. And your biceps' main job is to supinate your hand, to bring your hand up like that. And you really don't lose a lot of the strength with approximate. If your biceps tears down here, yeah, you have to fix that. But if it tears up here, typically you don't. And that's looking inside with the scope at a biceps that's just frayed and unhappy, and that hurts. So, and that's just rubbed in the same way that the rotator cuff has rubbed because it's right in the same area. So there's a couple things you can do for that. One thing we do surgically for it is to just cut it. In the same way that once it tears, it doesn't hurt. If you just cut it, it doesn't hurt. That is probably for a lot of people the right thing to do. It's hard to talk people into doing that oftentimes. And it's almost exclusively what they do in Europe. The other option is to do what's called a tenodesis, and I can't remember how long this video is either. So, and what that involves is basically taking the biceps and detaching it from where it lives and reattaching it right in that groove. So this is the biceps tendon here. This is the rotator cuff. That's a needle that's coming down through it. And this is another video that I got off the internet that you can find on YouTube. So right here is a little cutter. So he's actually cutting the biceps from where it attaches in there so that it's no longer going to rub. And then you come outside the rotator cuff. That's all rotator cuff tissue underneath. And then using this same little heat probe, you can actually find that biceps tendon. You sort of uncover the biceps tendon from where it is, which I think I'll get to pretty quick.
Cleaning house in there.
Yeah. So that's sort of vaporizes the tissue a little bit while it stops everything from bleeding. So then here's a knife come through, and then you can find, so he's taken that little ligament off where the tendon goes through that groove, and right underneath that ligament is going to be the tendon.
So there's not a lot of blood showing in there.
Right, so, which is nice, right? So that's the tendon itself. So the way that you manage the blood is that the anesthesiologist keeps the patient's blood pressure relatively low, number one. And then we pump fluid in, that saline that's in there that you're looking through is under pressure a little bit. So the pressure of that saline collapses the blood vessels a little bit so that they bleed less. This is taking a little bit longer than it needs to. But so they're sort of disconnecting the soft tissue attachments around that biceps. For a long time. And then we drill a hole right where we want that tendon to be attached into the bone. So there's a drill hole that goes right into the little groove. So that's the drill right there. Going very slowly. So there's the drill. So the drill has markings on it to tell you how far you go into the bone. And then there's the tendon attached to a similar little screw to the one that we use for doing the rotator cuff. And you can push that tendon down into that hole and then wedge it in there with a screw that wedges that tendon up against the bone. And that makes it so that it's still reattached and it doesn't, yeah, like in your thumb. And that makes it so that it can't pull out, and eventually that tendon and the bone heal together. So that's called a biceps tenodesis. And then the last diagnosis to talk about is adhesive capsulitis, which is frozen shoulder. So that's where that capsule, the lining tissue of your shoulder, basically shrinks up so much that things don't move as well. This can come for a couple reasons. You can get primary adhesive capsulitis where it just comes out of the blue. That tends to be most common in women sort of in between 50 and 65, maybe, something like that. Don't know why it's more common in women, but it tends to be. And it can be more common in diabetics, more common in people with hypothyroidism, but more commonly just comes out of the blue in women. Just for no reason. And so what happens is people's shoulder just starts getting sore, and it stops moving. It gets stiffer and stiffer and stiffer and stiffer. Sometimes people come in and literally they can't lift their arm up more than about like that. And then it can be secondary. So you could hurt your shoulder because you fell on it or something like that. And then you're babying it and you're not moving it. And as you're babying it and not moving it, it allows the ligaments to sort of tighten up, and then it gets hard to move. So this is usually also a dull, aching, diffuse shoulder pain. It's usually more diffuse than rotator cuff, which is usually more right out to the side. And then you lose motion. So with pure rotator cuff disease, it might hurt for the patient to lift their arm up. So you come in to see me and you think, oh man, I can't get my arm up. But if I take your hand and gently help you lift it up, it'll still come up because the ligaments allow it to come up. It's just that it hurts you to do that actively. Whereas in adhesive capsulitis, the patient can't lift it up, and then I say, oh, can I help? And it doesn't want to go up. And the second thing is that just like we talked about, the shoulder blade needs to move in addition to the ball and socket moving. And what happens is that the shoulder blade now has to be doing all the work in order to get the arm to come up because the ball and socket joint doesn't work very well. So what's interesting is that when it comes on just primarily, it tends to be if you do nothing with it, it tends to be about an 18-month to 2-year process. It comes on, it hurts, it freezes, and over 6 to 9 weeks, it gets stiffer and stiffer and stiffer and stiffer and stiffer. And then you go for some period up to 9 months or so where it's just stiff. Doesn't typically hurt all that much, but it's stiff. And then for reasons that are unclear, it tends to thaw out and all of a sudden start moving again. So there are some places along the way that you can try to beat it. But, 20 20 years ago, the word was, live with it for a couple years and it'll go away. People are less enthusiastic about that option at this point. So some gentle physical therapy to work on stretching those ligaments out can help. Anti-inflammatory medicines can help. A thing that we do a lot is cortisone injections. So I have Dr. Brennan, who also does the dry needling of the calcific tendinitis, under ultrasound guidance can put a cortisone injection inside the joint so that it gets right up against those ligaments. And if you do that and some therapy, that typically helps. You can do a manipulation under anesthesia where we just put you to sleep and push on your shoulder and stretch everything out. People tend to get about half of their full motion back if you do that. So if you can only get your arm this far and I go and do that, at the end of it you maybe get your arm this far, which can be an improvement and for a lot of people can feel a lot better. And then you can also go in surgically and use that same little zapping wand that he was using around that biceps. You can actually just cut the ligaments and that can allow the shoulder to get moving and then they tend to heal back down again. So what that looks like, oh, and I should just mention real quick arthritis too before we do. So what that looks like on here. Where is it? Is really just that those ligaments that are there just almost do like a shrink wrap deal. They just tighten right up and so therefore things can't move as well because it just tightens up. That's really all it shows about that. And then the final thing I guess we should talk about quickly is arthritis. Arthritis is much less common in the shoulder than you would think it would be. And what that basically is, again, is that the smooth surfaces of the ball and socket joint wear out. And therefore, instead of being nice and smooth as you move, they're rough and irritated as you move in the shoulder, and that can be painful. That can come on just because you get arthritis in the same way that you get at other places, or it can come on because you have a rotator cuff tear that's been there for a long time. And that is something that initially you can treat with cortisone injections and those sorts of things. And if all that fails, then you can do a shoulder replacement. And what a shoulder replacement involves is putting a new smooth surface on the bone. So we go in and make a cut on the ball. We use a little thing to make a space on the cup and put a piece of plastic in there, and that just becomes a new smooth surface for the shoulder. And my partner, Dr. Parsons, does a ton of total shoulders, and probably more than anybody else around. And then for people who have a large rotator cuff tear, there's a new procedure called a reverse shoulder, where when the rotator cuff isn't doing its job to hold everything in place and the deltoid's trying to pull up, it turns out that if you put a ball here and a cup here instead of the way it was designed, this ball now acts like a fulcrum that allows you to lift your shoulder up. So for people with large rotator cuff tears that used to just be sort of stuck with not a whole lot to be able to do, you can basically do the same operation in reverse, where you put the ball there in the cup, and that allows you to lift your arm up. And again, Dr. Parsons does a ton of those. That's what it looks like on X-ray wise. There's a stem that goes down into the bone, and then there's that ball on the cup.
It goes down right away there.
Yeah, it does. It does. Questions about shoulder things? Anything I didn't cover you were hoping I was going to cover? I want to show you some exercises, but then anything else I didn't cover that you, questions? Yeah?
When you talk about a long-term tear, what are you talking about time-wise?
You know, probably a subacute tear would be something that's happened in the last 6 months or so. A big tear that you've had. Doesn't mean, so you may have had shoulder pain for years. That doesn't mean that you had a big rotator cuff tear for years. It may mean that your tendon was just unhappy and then, you know, over time has torn more and more. So you could have a relatively recent tear even though your shoulder's hurt for a long time. Or you could have a tear where, you know, people come in where they're like, yeah, you know, 2 years ago I fell on my shoulder and I haven't been able to lift my arm since. Well, you know, I'm not sure I'm going to help them all that much usually in that case. So
So the cortisone injection, how long does that settle it down?
it will settle it down, and it'll settle it down, you know, forever if you fix what it was that got it inflamed before. So that's why I usually tell people that the cortisone injection will quiet it down. But then in order to get it to stay quieted down, you have to do the exercises and do the therapy in order to strengthen the shoulder up and get the mechanics to work and keep it, and hopefully that will keep it quieted down. If you have a big rotator cuff tear there that we didn't know about and we do the cortisone injection, then it's less likely to stay settled down forever. But if all you have is bursitis and you put that cortisone injection, there's a pretty reasonable chance that it would settle down.
For how long before you need another injection?
Hopefully forever.
Oh, good.
In the shoulder, we tend to not want to do more than sort of 1 or 2 injections because it can weaken the tendons a little bit too.
So if I'm understanding, it's muscle fitness that really makes a good shoulder. What are all the marbles knocking around, you know?
They just kind of feel like things are going crunch. I don't know, my shoulders crunch too. I think what that is, the thing that makes most sense to me of what that is that as the surfaces are all moving by, if there's just a little bit of wrinkles in those surfaces, they just kind of, rather than gliding nicely, they kind of catch as they go by. And that's what I think a lot of the snapping and popping that we all feel in our shoulders is. And as long as that snapping and popping isn't hurting you and you're able to go on about your business, you can ignore it. I ignore it pretty well in my shoulders.
Exercises cause that?
They probably help it go away in the long term, but they certainly, you know, to the extent that originally, you know, the beginning of starting exercise, your shoulder gets things irritated, that could cause a little more swelling and a little bit more rough surfaces. But in theory, as you continue to strengthen it up, that should feel better. All right. So with a stiff shoulder, there are several exercises that can help. You can take your good arm, the bad arm is the left arm there, the good arm is the right arm. You take a broomstick or something like that and just use that to try to help lift your arm up and stretch it out. So that can help you get it lifted up overhead. This is using the same bar to just try to really lift your arm straight up. So you just take your good arm to pull your bad one. And then to work on getting internal rotation, to get your hand behind your back, you grab a towel and put the towel, the right arm's the good arm, the left arm's the bad arm. You put that towel and just try to pull that arm all the way up in order to try to get it stretched in internal rotation back this way. And then the last one that's a pretty common problem is that people have trouble coming into internal rotation like this. So this is the bad arm and you lie on your side with your arm out and try to push it down this way, and that helps stretch the back of your shoulder. And you can do it, she shows it just with her lying perpendicular, but you can also sort of roll forward into it and roll back into it, and you change a little bit what ligaments you're stretching. So those are sort of the most common helpful stretches. And then the easiest kind of exercises to do in terms of getting things strengthened up around your shoulder blade and your rotator cuff are either to use dumbbells or to use a band. And you can do the same things with both. So this is with a dumbbell. So this is going to strengthen the back muscles of your rotator cuff, which are involved in rotating the arm out. So he's got a towel underneath his arm and just a really light weight. You should be able to do this 20 times or something like that. So, and if you don't have a dumbbell, you can just use a can of soup. So you just to rotate the arm out. And that strengthens up the back muscle, which is one of the ones that helps your shoulder get more space. And then you can do the exact opposite just with the same can of soup or the same dumbbell. To lift your arm in like that.
Can't you be standing to do that?
You can be you won't, not with a dumbbell because it won't put stress on that, but you can do the same exercises with a little band that you can get at the CVS or one of those places. And so this one is with the band attached to the door handle, and you're just doing the same thing that he was doing with the can of soup or with the thing, and you're just pulling out. And then you can do the same thing standing the other way to tighten the other side. So that was external rotation, and then
Rolled up towel.
just to give yourself a little bit of a fulcrum to rotate your arm against You don't need to necessarily do that, but it gives you a little fulcrum and it isolates that muscle a little bit better. If you have a band, you can also do what's called abduction to help just pull away, and this helps strengthen some of the stabilizers of your shoulder blade as well. So you want to strengthen both the shoulder blade and the rotator cuff. So, and then the last one. Last thing that's important to do is to strengthen up around your shoulder blades. So just doing push-ups against the wall can help really a lot with that. Just to tighten things up. And then the final thing, if you have a dumbbell or a can of soup, is just to bring it straight up, sort of straight in the plane of your shoulder blade to come up like this to strengthen up. I'm sorry? Yeah. Yep. Yep, exactly.
What about light weights this way?
Yep, that can be helpful too. Yep, so that does the bottom muscle of the bottom back muscle of your rotator cuff, the teres minor muscle.
And then what about to open up the chest?
That's exactly right. So people tend to get rotator cuff problems the more rotated forward you are, and most of the exercises that we all sort of think of as gym exercises are things where you're strengthening your chest and doing that kind of stuff, and the things that are more important are to do things like rows and that kind of stuff to try to get your shoulder blades back and your posture back, which opens up your shoulders and gives them more space. Yeah. I can, if you guys leave on whatever sign-up sheet, if you leave your email address, I can send you all this stuff. It's not on a website where you can just go to it, but I can send you on an email address.
What about if
sort
you
of.
registered online?
I don't think I saw your email address. At least the list I got didn't have your email address on it.
Oh, okay.
So, but if you leave so what'll happen is, so this is a app that, as I said, it's been around for a couple years. I've actually been using it for a couple years, but just in the last 3 or 4 months, they've gotten it so that it's got a portal that allows us to send stuff to patients. It's really pretty cool. Allows me to, so when I see you in the office, I can show you the videos. I can take a picture of your MRI and circle where your rotator cuff tear is and all that kind of stuff and send it to you, which is I'm really liking using it. But so I can do sort of that list of general exercises and send that to you, and it'll come up in email. Yeah.
What do you recommend if you, I've already had surgery in one shoulder, so, and it wasn't rotator cuff, but now I was starting to have pain in the other shoulder, and I didn't want to get to the point what do you
Right.
recommend, just go and have it looked at? Dr. Buckley did mine.
Yeah, I mean, you can take a look and see what it is. The other thing you can do is just make sure you're stretching out. Start by doing these exercises, sort of stretch it out and strengthen it out.
That's what I started doing, starting that, and then I could start doing strengthening, but to go easy because it's.
Yeah, start with doing it kind of every other day. We'll take anti-inflammatories as long as it's okay with your blood pressure and all that kind of stuff. But then start doing relatively low reps every other day, and then sort of slowly build it up with really, really light weight.
And then how long do you go before you suggest
That you check it out? I don't know. If you're not getting better over a couple months of doing that, if you can't sleep at night and stuff, it's probably
That's pretty much where I got.
probably reason.
So I was just trying to.
Yeah, if you're not there yet, you don't necessarily. If you're able to lift your arm, you seem to have reasonably good strength. The likelihood that you have a big rotator cuff tear that's going to be hard to repair, I think, is low. And most people that don't have a rotator cuff tear with a good exercise program, the vast majority of people will get better. Anything else? All right, great. Thanks for coming.